Only somebody that practices at Clinton Crossings would identify their practice as CC 110 channel. It's like your Army call sign or something. That's a whole different thing. It's 5:30. I know we're only about halfway to our expected attendance. Should we give it another minute or two? Okay.
There's someone in the waiting room named Pete Manero. Does that sound familiar to anybody?
It does not.
I'll give everybody 1 or 2 minutes to get set up and then we'll get rolling.
Check it, make sure it works.
It's on here, isn't it?
Daddy, is Mr. Joel staying
Nobody's
for
saying
dinner?
anything.
Mommy, is Mr. Joel staying for dinner?
We'll give them 1 more minute. Bob McCann can't be here tonight, so I'll say we won't punish the punctual. Just so I can feel like he was here really.
I just checked one square in Bob McCann bingo.
Everybody has to drink if you're holding the bingo card. Yay. And we seem to be cruising out to about 50 folks. Should we go ahead and start rolling? Sure. Okay. All right, everyone. We are going to go ahead and get moving. Just be respectful of everybody's time. And we actually have a pretty good agenda for tonight. So I want to make sure we leave plenty of time without going over. So welcome to everyone. Thanks for showing up tonight. We're going to give this format a try. Hopefully this is a little bit more comfortable than trying to do it in the Advancement Center down in Rochester. But nonetheless, we'll give this a try and see if this works for everybody, and glad that everyone could join us. It has been over a year now since our last clinical grand rounds. Thanks to the
I
pandemic.
want to wear this.
It is nice to get back into the swing of things again, get back into regular talking about normal value-based care delivery for the first time in about a year or so. So for those who I don't know, I'm Chad Teeters. I'm the Executive Medical Director for HB. and I will be emceeing tonight's events, but we have a slate of speakers that I'll be introducing as we go along. As we had pointed out in the notices for clinical grand rounds, this is going to be more heavily focused intentionally towards adult primary care providers. We've been trying to create kind of a balanced approach to the subject matter, and we anticipate that we'll have a more peds focus in our normal fall clinical grand round schedule. So hopefully this will be apropos to those joining us tonight, but hopefully we'll have a little bit of something for everybody. Folks probably notice in the chat feature that you see people adding their names in practice. You can see it on the screen. So for those who are just signing in, if you could just add your name and practice name to the chat function, just so we make sure we get our attendance correct. So tonight's big focus is we want to review kind of what our quality and clinical objectives are going to be for 2021. We're going to talk about our refocusing our efforts to drive our performance as a network. So for years, we have been very quality metric focused. However, as we've talked about many times, our contracts reward us both based upon quality metric performance, but also on our ability to bend the cost curve. So in the last year or two, a little bit of interruption during the pandemic, we have developed these programs that we call IPCs, or Integrated Practice Committees, which are clinical initiatives that are meant to enhance quality, improve care delivery, but also have a cost focus to try to bend that cost curve, ultimately improve our ability to earn gain share and then return that gain share to all of you. So tonight we're going to talk about our 2021 quality metrics. We're going to review those IPCs that we are working on and how we think those are going to bend the cost curve. We're going to talk about our pharmacy initiatives, which are also very cost focused. And then we're going to talk about a new type of reporting and engagement design that we've been working on for really about a year or so now, that will be the next evolution of the Triple AIM report that you've seen previously, which will be a new way to engage you in your practices in both the quality and IPC efforts, and provide actionable feedback to you at the point of care, so you know which patients in your practice are applicable to those IPCs and quality metric needs that are gaps. So hopefully it provides the next level of information on top of Arcadia, but also helps to give more transparency to what it takes to earn the gain share, and then gives you and your practice a better idea throughout the year of what you can expect in gain share based on our performance. Finally, as I think everyone knows, Daryl Sharp, who is joining us there in the Hollywood Squares, has retired but not gone away. She is still in a senior advisor role, but has stepped down as the director of care management. And Elisa Stetzer, who was overseeing the care management organization for the primary care network, is now over the entire care management organization in Daryl's former role. So she's going to talk to us a little bit at the end of the presentation about the next iteration of the care management enterprise. So that is going to be our plan for tonight. And we will field questions along the way, but it may be easiest to put those questions in chat so that we can kind of keep an eye on them. And then I'll make sure to ask the current speaker those questions at the end of their presentation. So without further ado, our first speaker this evening is Renee Sutton, who everyone knows and loves. She is our Senior Director for Provider Network Management, and she is going to lead us off by talking about our new reward incentive plan, which is going to be the new iteration of how we go about earning the gain share dollars, and how those dollars will be paid out by AHP to you and your practices. So this will, as I said earlier, focus not only on quality, but also on our ability to bend that cost curve, which is going to take us to that next iteration in value-based care delivery. So without further ado, I will turn it over to Renee.
Thank you, Chad. So I want to start my presentation by just making sure everyone understands that the gain sharing equation. How do we earn dollars under our value-based contracts that ultimately is what funds our operations, but also our incentives? And I think folks are familiar with the graphic that's on this slide right now, that the healthcare value equation is quality over cost. Similarly, the gain sharing equation is quality and cost, in that we only earn gain sharing when we hit quality targets and perform under the budget. We have to do both of those things in order for there to be dollars for us to share with our providers. So to make sure that everyone, is on the same page, that is how the dollars come into AHP. But our prior PCP quality incentive plans only earned providers dollars based on their performance to quality. So up on the screen just shows our previous iterations of the PCP quality incentive plan really only earned providers dollars based on their quality performance, on their points that they've earned in the Arcadia Analytics dashboard to those measures. PCP gain sharing, so this isn't the quality incentive payment that we've been paying, but the gain sharing that we usually pay around August or September in the year following the performance year that we earned gain sharing. Providers have been, PCPs were earned gain sharing on a basis of quality and attribution. The number of lives on their panel was the way that we paid out gain sharing. We've had a number of iterations of that. We started out just paying everyone a base and then a per member amount based on the size of their panel. And then we added quality as an additional factor in the gain sharing payout. So that's where we were. And we redesigned, though, we sat down and wanted to redesign the PCP reward plan to better align the incentives with the gain sharing equation, so that the payment, that the payments that providers earn, the primary care providers earn, is based on quality and cost performance. So what I'm going to present to you now is the new PCP reward plan. This is going to be effective for performance year 2022. So what I'm telling you now, we have some time to live into. One major feature of the new PCP reward plan is that it's going to combine the quality incentive payment funds with gain sharing funds. So our PCPs are going to earn just one reward payment instead of the prior methodology where you earned providers earned a quality incentive in March, and then they earn their gain sharing in the August and September timeframe. We're going to combine those pools of funds into one PCP reward plan payment. The first performance reward under the new plan will be paid out in August, September 2023. So it seems like a long time from now, but just want to help you understand the timing. So it's going to be effective for performance year 2022, but just like it's always been for gain sharing and now this new PCP reward plan, it's going to be paid out in the year after that performance year and around the August, September timeframe. The PCP reward plan has three factors, three payout elements. The first is your performance to quality measures. So 60% of the possible full incentive award is going to be based on a PCP's performance to quality, their performance to the quality measures in Arcadia. Those, hopefully some of you are familiar with what that image is. 30% is going to be based on your performance to IPC and pharmacy targets. And you're going to hear more about that later in tonight's presentation about IPCs and pharmacy targets and what those expectations are, and that will lead to you earning 30% of the total incentive. And then finally, citizenship, 10%, which is going to be based on your participation in certain AHP initiatives. And I'll talk about that in just a minute. So citizenship is brand new, and we wanted to add this as an element to the PCP reward plan because we thought it was important to reward providers for some activities and behaviors that we think are important to the network's success. I'll review some of what those activities are. But the plan is that we're going to decide on whether or not a provider has satisfied the citizenship requirement first based on if the practice has satisfied certain components of citizenship. And if the practice has done 2 or more of these activities, then that's going to earn the citizenship incentive for every provider in the practice. But sometimes at the practice level aren't doing these activities. They're not going to satisfy those components. But there are individual providers in the office that may satisfy the citizenship component by satisfying some individual citizenship requirements. So at the practice level, these are some of the things that if the practice does these things, it would earn, if they do 2 or more of these items on this page, they would earn a citizenship incentive for every provider in the practice. Some of those activities are that your practice manager comes to our practice manager meetings regularly, or the practice as a whole is participating in an optimization or an administrative project. So 2 or more things on that list earns every provider in the practice the citizenship. And then on the right, if the practice hasn't satisfied it based on those activities on the left, and on the right is the list of things that an individual provider would earn by participating in these things. Like those of you attending this evening would check a box for your citizenship award. So we hope to give you lots of opportunities to earn that citizenship incentive, both on the practice side and the provider side. I know I'm flying through this, but I assure you we'll be talking a lot more about this over time to make sure that you understand the new reward plan as comprehensively as possible. We want to point out that this new reward plan is going to apply to all primary care providers, private or employed, but we do need to point out that we do pay the incentive out to the entity with which we're contracted. So for the private practices, typically we're contracted with the practice. So those dollars are paid to the practice in the practice's name, and it's up to the practice to share it with their providers as, whatever their arrangements are with their providers. While hospital employed providers, their incentive dollars are paid to the system that employs you. But it's our understanding that often these dollars are rolled in to provider comp plans. And so they are making their way to you, albeit indirectly. I went through that really quickly, and what some of you might be asking, so there's a new reward plan. It's going to be based on my performance to quality, which it always has been. There's a new element, performance to cost, based on your activities under these clinical initiatives or pharmacy initiatives. There's a citizenship piece. So it got a little more complicated. So you might be having questions like, how will I know how I'm doing? Where do I need to make more effort? Which patients are impacting performance? What incentive am I on track to earn? Well, I don't want to steal anyone's thunder, so I'm just going to say a spoiler alert that the tool we're going to give you is the new provider engagement report, and Christy Howard, our Director of Information Management, is going to be covering that later in the agenda. But that's going to answer a lot of your questions about how what you're seeing in this reward plan is going to be, and your performance under it will be reported to you regularly. So, in summary, the quality incentives from 2021, that's all going to remain the same. So this year you're under the old plan where we're going to pay a quality incentive in March and gain sharing in the year following in 2022. So this new reward plan is only going to apply to the 2022 performance year, and the first payout under this new plan is going to occur around August, September of 2023. That provider engagement report, the spoiler alert that I gave you that Christy will be covering later, that's going to help you monitor your performance. And all throughout the remainder of this year and during 2022, we're going to continue to engage you through clinical grand rounds, through our physician advisory meetings, through individual practice visits, engage you and make sure that you understand your performance expectations relative to quality and cost and citizenship, the resources that are available to help you optimize your performance, and then finally how to access and utilize that provider engagement report. So I'm happy to answer any questions, and always available even after the meeting if you want to reach out and ask me anything about our new PCP Reward Plan.
Thank you, Renee. There are no questions in the chat. Any questions briefly that folks have before we move to the next section? Hearing and seeing none, I'm going to keep on rolling. And please feel free, you can put your questions in the chat at any time. We'll come back to them later, even if there are questions about a former section, so that's A-okay. So I'm going to move on next to the 2021 quality measures unveiling, if you will. So the goal of our quality measures effort every year is really to restrict the number of measures so that we're not dancing to too many things and asking of you to attend to a host of measures. We try to refrain from significant shifts, meaning not a lot of new measures being added, not a lot of old measures falling off. We ideally like for these measures to be good, solid reflections of what we think reflect important care delivery monitoring. And therefore, we expect that those measures will be enduring and not just one-hit wonders for 1 year or another. The final piece is to try to balance the number of measures and the weighting of those measures between adult and pediatrics so that there's equal opportunity for all of our providers to perform without significant risk of loss of points if one metric underperforms over another and you only have 3 or 4 metrics that you can attend to. So I think this year, we've gotten a little bit better at this every year. And I think this year is probably an improvement still. So just as a course of reminder, we have certain measures, a menu of measures, if you will, that are presented to us by the payers each year. We have a bit of negotiation around which of those measures we feel are important and which of those we're willing to take into our contract. And then largely with some broad guidelines, AHP assigns the point value of each one of those metrics to achieve our total point score, which adds up to about 100 total points. Then there are thresholds, and those thresholds are national benchmarks. They are not negotiable. They are not decided by us. They are basically HEDIS CMS set thresholds based on national levels of performance historically. So there's a 25th, 50th, 75th, and 90th percentile of performance, and we earn escalating percentages of the points available based on crossing those thresholds, with the maximum points achieved by crossing the 90th percentile or crossing over a quartile. So if you jump from the 75th last year to 90th this year. And then finally, the definitions of these metrics, again, are not something that we're cooking up in the back room. These are nationally determined definitions with inclusion and exclusion criteria that we have to follow. So we can choose the measure, but we cannot choose the threshold or definition. Next slide. So as I said, important things for us. Limit the amount of volatility between the metrics. We don't want a lot of new metrics. We don't want a ton of metrics falling off. Number 2, we want to evenly weight it across adult and pediatrics. Number 3, we want these metrics to be somewhat equally weighted as much as possible. So what you'll see here on the left-hand column are the metrics that we are contracted for this year. What you'll notice is there is only one flag for a new metric, which is fall risk management. Now, many of you who've been in the network for a couple of years will say, that doesn't sound that new. We did fall risk before, and you are exactly correct. So in 2019, fall risk was on our menu grid of metrics. In 2020, the payers had actually taken it off of consideration because we had done so well. However, there has been renewed focus and attention on fall risk, both because it's heavily favored in the star weighting for payers for CMS, and because during the pandemic, when they stopped focusing attention on it and people were at home, we saw a lot more falls. So because of that, it was a very important interest to Excellus. And so we brought it back this year because it was a metric that we had already put quite a bit of time and effort into and had performed quite well historically. What you will see is that the attribution of the metrics to adult and pediatrics is roughly split, and the point weighting on each metric is exactly split. So each metric is worth 10 points, whereas you can see the point weighting last year was more variable. So I think probably the best we've done this year as far as retaining a contrived number of metrics. There have been a couple that have fallen off, metrics that were retired. So for instance, adult BMI is no longer, because the percentile achievement, the top threshold was like 98 point something percent achieved. It was no longer considered a viable metric. Diabetic nephropathy screening also fell off, but that metric is actually being reimagineered. But because there are no thresholds for the new metric, it is not currently up for grabs. Imaging for low back pain, we had pretty much topped out our performance, both in cost reduction and in utilization, so there was nothing more to be gained. And the well child 3 to 6 measure, really all of the well child through adulthood by year has now been taken away, and there will be a well care 3 to 15 months to 20 years metric that will come back in the future. But again, there are no thresholds to that metric currently. So the metrics that we got rid of, we either were already performing so well that they were no longer viable, or there are newer metrics that are being reformulated and do not have thresholds to perform to in this calendar year. Next slide. So here are the 90th percentile. And as you can see on the right-hand column, the percentage change compared to last year. So every year, these thresholds change based on what CMS sees across the nation as performance. In general, the amount of fluctuation is relatively small. So the adolescent immunization combo 2, that was a relatively new metric, and folks have started performing to it. So that one has had the greatest increase in performance to achieve the 90th percentile. But you can see for almost all of the rest of the metrics, it's largely flat or slight decrease, either due to the pandemic or just national decrease in performance overall. Colorectal cancer screening is another one that we have always performed exceedingly well in. We are not only above the 90th percentile nationally, but we are well above the 95th percentile nationally. So even though there is an increase here, historically, we have performed very well in that metric. So it's not one that we have a lot of concern about. The rest, I think, are pretty commiserate with prior performance thresholds. Next slide. All right. So that is the 2021 metrics. So hopefully the good news is not a lot of change. Going to be very similar to what you performed at last year. Equally balanced between adult and pediatrics, and all metrics are now weighted equally. So no one's getting favor over another. So that is the good news. Now into our clinical initiative IPCs. These initiatives are largely run through AHP. Kim Povic and I oversee these. There's a lot of development that goes into these based upon utilization and cost data that we receive from the payers in a multitude of different reports. If we see wide discrepancies in cost or utilization, then that suggests there's an opportunity. We then develop what we think is a potential engagement opportunity for how we could address it. We run it by subject matter experts. If it seems that that's a viable approach, or if there needs to be amendment to it, we do that. And then we go back and calculate what we think the cost savings would be. The goal of these IPCs is to achieve about a $10 million reduction in our contractual spend annually. When we look at AHP, we tend to distribute somewhere around $8–10 million in gain share annually. So to be able to continue to hit that, we need to continue to achieve that cost savings approach. So this book of business that we're going to show you tonight meets or exceeds that anticipated $10 million savings compared to our contractual performance last year. So the first of the IPCs that we're going to discuss is readmissions. So this is our 5 contacts initiative. Many of you are probably thinking to yourself, we've heard about this before. This has been ongoing for a while, and you would be correct. Readmissions is probably the first and most well-baked of our IPCs at this point. We began piloting this at the end of 2019 at Highland, and had such a good success with that program that we were targeting a 15% reduction in readmissions, but exceeded that at just over 17% reduction. And so therefore we decided to begin the rollout of this. That was anticipated to happen in 2020, and we did begin that process in early 2020, only to be derailed by the pandemic. However, we did relaunch the rollout in November of 2020, and we are now across all medicine units at Highland and most of the general medicine units at Strong, constituting the entire 6th floor and the 19200 med psych unit. Now at Highland, we also include all off-tower medicine patients and observation unit patients. We intentionally excluded surgery, peds, OB, and psych discharges. One, because those readmission rates are already very low. And 2, because many of those services, there's a bundle of care payment that is already takes into account readmissions. And so there's already processes in place to attend to that. So it did not seem that that was an area that warranted intervention, whereas the medicine service readmission rate historically hovers somewhere in that 10 to 12% rate for all cause readmissions. Next slide. So how are we doing? So this is since the rollout in November. And what you'll see is baseline, we had a readmission rate of about 12.8% in November, December, down to 9.3% in the end of 2018, beginning of 2019. In the pandemic, so starting in November of 2019, when we first started this pilot, you can see our readmission rate across the system had actually gone up. This is a generally true statement that that readmission rate has slowly climbed year over year. But when we fully rolled out the 5 contacts program, if you see between November of 19 and November of 20, we dropped from a readmission rate of 14.8 to 11.6. In December, 13.5 down to 11.4. Then January hits, and you can see we start to plateau in January and February. Remember, January, February of 2021 is when we were dealing with the bulk of the pandemic surge in the hospitals. So patients were getting discharged earlier if they didn't have COVID because we were crunched for hospital space. And that oftentimes meant that they were getting readmitted at a faster rate. Then you get into March and you see the bottom really falls out of the readmission rate in March and April of 2020. That's because the pandemic started in March of 2020 and nobody was coming back to the hospital or coming to the hospital at all because they were scared to death of what was going to happen. So now we're comparing ourselves in March and April of 21 against the pandemic experience of 2020. It makes the comparison very difficult, but these are all variables that we're going to have to attend to. And it's the reason why we're trying to compare ourselves back to the 18 and 19 experience, because that's a more baseline normal year, if you will. And if you look year or month over month with the 5 contact program at full expansion versus our baseline pre-pandemic, you can see that we are performing above or better than the readmission rate that we historically achieved. So right now, I would say we are just about on target to achieve our 15% reduction goal compared to the pre-pandemic readmission rates. This is a very complex project, has a lot of moving pieces, but it really centers around those 5 points of contact between hospitalization and 30 days post-discharge for our medicine discharges. So thank you to all of you for what you're doing. You can see here that this is really having the desired effect, and we're going to continue to roll this forward. There's interest both to migrate this to the other affiliate hospitals, and because of the success, there has even been some interest for potential adoption across town within the GRIPA network as well. So more to come on this in the months ahead. Next slide. So the next large initiative is our post-acute care initiative. And this is the one that really was a focus on trying to reduce our cost and utilization for patients going to rehab after an acute inpatient stay. So what we found is that if you look from 2018 to 2020, year over year, our number of patients who were going to rehab was increasing, but our cost per rehab stay was increasing at a faster rate than was our number of discharges. So it seemed that there was opportunity there. When we then broke it down further, what we found was that there were very high value facilities that had controlled length of stay, very low readmission, and very low ED utilization in that 30 days post-hospital discharge. There were also lower value facilities that had higher length of stays, in some cases up to 25% longer length of stay and up to 40% higher readmission or ED utilization rates. That translated into much higher costs of care for those facilities. So to try to address this, we partnered with 7 facilities. This was a foray completely outside of our member network. So in readmissions, we were dealing with our hospitals and our primary care teams. Here, we had to go outside of AHP to develop partnerships with nursing homes who are not necessarily part of us, but we found 7 willing partners in the 7 facilities that you can see here. We chose them because they all tend to be very high functioning participants. They had very low utilization, very controlled length of stay, and tended to take about the middle of the road as far as complexity of patients. They didn't necessarily take the sickest, but they certainly didn't take only the healthiest patients either. We launched this in January, February of this year. And I will say that the goal of this really was to preferentially discharge our AHP Excellus patients to those 7 facilities. In the beginning, we did not have any other criterion or restrictions that we placed on these 7 facilities because we chose them because they already did the utilization well. So what our intention was, if we sent more patients to these 7 facilities, there would be less cost of care and less utilization because historically they were already doing this better than most. Our intention going forward is to eventually take those lower value facilities and steer patients away from those facilities towards the higher value facility. So right now we just say, please pick these 7. The next iteration would be, don't pick these 10, but preferentially pick these 7. And then finally in phase 2, if the first 2 phases are successful, the first 2 parts, I should say, the goal was to say, now we have to create a broader network of more nursing home facilities so that we have an adequate bed number and geographic scope of our network. And then we want to contribute or take attribution for all Excellus lives, if potential, that are going to rehab so that we can reduce that cost of care and then earn gain share from that entire pool of patients. It may be a larger pool than what we are currently contracted for in our aqua value-based arrangements, but because this would be a separate kind of finite window of time, there's interest both from AHP and Excellus in taking on that larger attribution if possible, so that there would be more potential for gain share earned. Next slide. So how are we doing? The answer is it's not clear yet. So what I will say is we've had great partnership from the facilities. We've done a lot of work with the discharge coordinating teams at the hospitals and the nursing homes and the primary care teams in your offices to try to get everyone speaking a communal language and sharing information. That's been difficult. Nursing homes just have a different way of going about their care delivery and their communication. So that's been a challenge. If you look at this, you would say, wow, your 7 preferred facilities are actually taking a lower percentage of patients now than they were before you started this process. So you're actually doing the exact opposite of what you said you were going to do. The problem is the pandemic. So when the pandemic hit, many of these nursing homes, which are some of the largest rehab providers in the region, either had staffing issues or had to close units because of COVID outbreaks, and therefore weren't able to take patients at the rate they were before. With only 7 patients in that preferred network, the patients have to leave the hospital and go somewhere. So that meant that they were going to other facilities. While the lower value facilities did see a small increase in the most recent couple of months, in reality, what happened is that in-between group, the group that's not the preferred and not the lower value facilities, really was taking that lion's share. That in-between group is who we suspect would be the other partners for our high value network in that phase 2 contracting. So it is good to see that we do have that capacity, but I don't think we're ready to say that this is not working as of yet. It's just there are other variables that we have to take into account when we analyze the success or failure of this program because of the effects of the pandemic at this moment. We do not yet have, because we're only a couple months into it, we don't have robust cost and utilization data. That literally should be coming within the next weeks ahead. So that will really tell the tale of how good a job we're doing at controlling that cost and utilization and reducing the total spend on the rehab population. I will say overall, the volume of patients going to rehab compared to prior years is less. And that's a general population phenomenon that since the pandemic, patients are more resistant to going to rehab than ever before. So they are preferentially going home if at all possible. Next slide. So this is the other large initiative for this year, which is osteoarthritis. So what we have seen is that there are as our population is aging, There are ever increasing numbers of patients who are going on to large joint replacement, but historically about 30 to 35% of those joint replacements leak out of the AHP network. And when that happens, the joint replacement is both more costly, the patients are more likely to be readmitted, they are more likely to be reoperated on in 5 years, and they are more likely to require post-op rehab placement. So it's both a cost and a quality issue for our patients. So to attend to that, what we've realized, and in talking to many of you, is that there hasn't always been the capacity to get these patients to our in-network joint replacement team. So what we decided was to develop a care pathway where we could deal with these patients earlier in their course of disease, try to implement conservative management techniques to hopefully decrease the likelihood that they need joint replacement, or at least significantly delay the time to joint replacement. And then by creating this longitudinal care pathway, they will already be within the network so that if they fail conservative management, they can automatically move into our joint replacement team to have that joint replacement done in network and contain those costs and utilization. So our first pass on how to do this, and I'll be very honest, we got lucky. We randomly chose patients who had 3 or more visits for the primary diagnosis of large joint osteoarthritis within the prior 12 months, but had not been seen by an orthopedic surgeon during that time. So the consideration there was that osteoarthritis was becoming an increasing factor in their day-to-day life, but they were not getting specialty care already. When we did that, we found that this constituted about 2,000 patients that were up for grabs. We then talked to our orthopedic colleagues, and they have a non-operative team, which is predominantly sports medicine trained physicians who specialize in this non-operative management. And we constructed a care pathway that is multidisciplinary and involves behavioral health, physical therapy, orthopedics, sports medicine, and to develop that continuity plan of how we would try to conservatively manage these patients. What we are hoping to accomplish is that we will reduce the out-of-network leakage, as you see at this green arrow here, by 50%. And then of those that go to joint replacement, we'd like to decrease the amount of total joint replacement by 20%. So in talking to orthopedics and in looking at the data from their end of the world, we think that these are potentially achievable. If we can't reduce the total joint replacement by 20%, we think we can at least delay proceeding to joint replacement by 20%. And there is good data to show that even delaying joint replacement is associated with better cost and quality outcomes. Next slide. So this one we are getting ready to launch. So we've been in a lot of work of how the referrals will work, how the repayment structure will work for orthopedics. And we are now at the precipice of being able to go live with this effort. We have reviewed this at PCP advisory meetings. We've talked about it at practice administrators. We've reviewed with the primary care network leadership. And we wanted to present it here to you guys tonight so that we got as large an audience as possible. Understanding that you're going to want to hear from that non-operative team more so than just hear it from us, we have also scheduled a Zoom session 1 week from tonight where the non-operative orthopedic team will be available to discuss their care plan for this non-operative pathway, answer your questions, talk about how that referral process will work and what you can expect from them. So I hope that many of you will be able to join to get that exposure, meet that team, have your questions answered. And then our anticipation is to be able to go live with this initiative on August 1st and roll forward from there. Final slide. So if those are our big rollout initiatives, we have to have some things in the hopper that are on pilot phase that will then hopefully become the IPCs of next year. And what you see here are the 4 pilots that we are planning to launch this year. So number 1, we've heard loud and clear from our pediatric team that as patients age out of their pediatric practices, there is not always an adult medicine practice that they can easily land those patients in. When that happens, we lose attribution of those patients, which means that our patient population tends toward an older and sicker population, which has a higher cost of care. So it benefits us as a network to keep our younger, healthier patients in network by transitioning them to adult medicine providers, and also providing that preventive care when they're younger so that they don't then present when they're older with more advanced disease. So the goal here is going to be to try to do that either by live or telemedicine engagement, knowing that this is an age group that will be more welcoming of telemedicine physician visits. And we think we have a process that we can trial that this year and get that up and running. The next is CT screening for lung cancer. So Western New York has some of the highest smoking rates in all of New York State and has some of the highest lung cancer incidence. It's also with the advent of low dose CT scanning. It's a very low radiation, quick and cheap. It costs about $170 per scan to identify these patients. And the goal here is both to provide smoking cessation for those who are still actively smoking, but then also identify early stage lung cancers to potentially identify disease in its curative stage, but then also decrease the costs of later stage radiation and chemotherapy, which with the advent of immunotherapy for lung cancer has become $100,000 plus per year treatment costs for this population. So this is one that I think will have significant benefits for morbidity and mortality. And many of you probably are aware that the U.S. Preventative Task Force just dropped the inclusion criteria to patients as young as 50 and those with as little smoking history as 20 pack years just in the last couple of months. So this one will be going live soon as well. The next phase, and this has been a request for a while, is to try to branch out to not just be so primary care focused. So the next one was pediatric complex care. These are kids who have complex medical conditions, oftentimes multiple complex medical conditions, but they may come from quite some distance. So when they come in to seek care, they may come to see their pediatric cardiologist, but their G-tube fell out, but the pediatric GI doc can't see them that day. So they get sent to the ED to have their G-tube replaced, and they wind up with a hospital stay that results. That results in a significant cost of care. Multiple other pediatric centers have invoked this complex care management care and seen as much as $1,000 per or $7,000 per year reduction per child in the total cost of care for that individual. So this will be something that Golisano is already working on, but we're going to try to expand that access to others of these complex kids across the network. The final is complex care for behavioral health. So we both want to provide an additional support through embedded and centralized behavioral health care managers to try to provide more effective care within the primary care setting of patients with behavioral health conditions, but then also better identify and triage patients that cannot be adequately maintained in the primary care setting and get them in to see psychiatry more efficiently. So we are currently applying for some grant funding to get this launched. And we hope to be able to launch this in at least a handful of practices within the next couple of months. And I think that is all I have for the IPCs. So the summary, so things that you can expect this year. So with readmissions, your care managers are already very well versed on the 5 contacts program. So working with them and working with the hospital discharges to coordinate those 7-day follow-up visits post-discharge and making sure that we're achieving that high transitional care for our high-risk admissions is going to be key to reducing that readmission rate. For post-acute care, basically we almost want to invoke the 5 contacts program for our nursing home rehab discharges to decrease that utilization, because their biggest risk window is when they discharge from the rehab to home, because these are some of our highest risk individuals because of advanced age and frailty. And then osteoarthritis, we will be working with your teams and your care managers to provide a list of patients who have had these multiple visits for primary diagnosis of osteo, for your team to review and determine if they would be amenable to this conservative management pathway. And then obviously we will also be welcoming any organic referrals as you identify patients, whether or not they've had 3 or more visits, whatever criteria you think are important If you feel like they would be best served by management in this conservative management pathway, we would, of course, welcome them into that cohort as well. So we will continue to provide you updates on these three. We'll be talking to you more about some of those pilot initiatives for opportunities to trial those in your practice over the coming months. And hopefully we will find a huge amount of savings so that that increases the gain share checks that we can pass back to you. All right, I did see one or two questions in the chat. So does this mean UNC will actually provide long-term medication management for psych? So yes and no. So the goal is first and foremost to see what we can better manage within primary care with the assistance of these behavioral health care managers. But if there are patients who need to be seen by psychiatry, the anticipation would be to move beyond their first come, first serve practice, which they currently utilize, and try to triage those patients more efficiently so that we can get them seen by a psychiatrist in a more timely manner, if that answers your question. And I think the rest Renee answered for me. So if there are no other questions, I will introduce the good Dr. Dobson. So all of you know Dr. Dobson. She always gets to highlight. Everyone always talks about the pharmacy sides of the presentation. I'm only just a little bitter about that, I will admit. So Erica is our manager of pharmacy services and the queen of all things pharmacy. And she will be talking to us about our 2021 pharmacy initiatives. So Dr. Dobson, take it away.
All right, thanks, Chad. Well, thanks everyone for being here with us tonight. I can promise that my children are out of the house, so they won't be making any contributions to this presentation. However, my dog may make an appearance or two. He's being a little crazy tonight. But I'm going to talk to you a bit about our 2021 pharmacy initiatives. I know we're already mid-year, but the time seems right to reset around our pharmacy initiatives, which we've partnered with you on for many years now as one way to start to bend the cost curve, particularly the pharmacy spend in our contracts with payers. And really when we took a look at how we wanted to design pharmacy services for AHP, we designed 3 key strategies that we thought would be important towards creating a more patient-centered pharmacy service that would also support clinician medication management, ultimately leading to improving population health and medication-related outcomes in value-based prescribing and drug use. And one of those key strategies is really related to these pharmacy initiatives, which is to create an efficient drug utilization management program. So all of the pharmacy initiatives really fall under that strategy. And they shouldn't sound very new to you because it's things we've been doing together for many years, although our targets change a bit from year to year. Next slide. So each year we take a look at what we've been doing in the previous year as we enter a new contract to look at our success in the previous year, as well as new targets that we might identify based on drug approvals, where we are seeing spend across the network. And we partner with the payers that we're contracted with, so members of Excellus, members of MVP, pharmacy experts from Primary Care Network, the U of R health system, and come up with a diverse portfolio of pharmacy initiatives that are really designed to target low value, what we term low value prescribing. So really we're looking for mainly agents that could be substituted because they're equal in terms of both indication and efficacy, but they have lower cost. And so as a result, partnering with PCPs, our strategies really focus on substitution or preference of cost-effective medications. So if you look back at our 2020 pharmacy initiatives, which one might say COVID took much more precedence over. But when we started the year out, we continued many of our pharmacy initiatives from 2019. So we continued to focus on Humalog, reducing the use of brand stimulants across the network. And then we introduced 3 new strategies at that time. The ones that are in bold are those that really are targeting, that are switch strategies. So switch from expensive drug A to lower cost drug B or C. And as a result of these efforts in 2020, we did accomplish a cost avoidance of around $4.1 million. So we thank you for your partnership and hearing us out in some of these initiatives and taking action. Next slide. So as we look towards 2021, we have some new initiatives that we're going to be introducing today, and then some continued. So they should sound familiar to you, things that we were focusing on in 2019, 2020, some of them back to 2018. So we're going to continue our Humalog initiative, our deprescribing for patients on combination GLP-1, DPP-4 inhibitors, generic, looking to prefer generic inhaled corticosteroid and long-acting beta agonists, continuing our Glumetza initiative. And then, newly, we're going to be talking a little bit about NSAIDs, HIV PrEP, and Trelegy. So I'll get a little into that. Next slide. Later this week or early next week, you'll see a follow-up come out. Every year we issue, sort of a summary of all of the pharmacy initiatives that we're focusing on, which include what I'll discuss today, sort of what's the prescribing message that we'd like to share, what's the rationale behind it, as well as how you as a prescriber could take action. These are our initiatives that are mainly PCP focused, largely in the adult space, as we mentioned. We do have other pharmacy initiatives I'm not talking about today, which includes, partnering with U of R health system to prefer biosimilars for medical pharmacy spend, as well as partnering with specialty pharmacy to prefer generic Copaxone for some of the specialty indications in MS. So really what we're talking about tonight is PCP prescribed, potentially PCP prescribed agents. So take a look for that later on. So the first one, Humalog, just a refresher, again, we're continuing this. This is something we have been focusing on. There was insulin Lispro, which is an authorized generic, so it's not substituted right at the pharmacy, was introduced in late 2019 and offers a 50% cost reduction to brand Humalog. So our message here is to, prefer the use of this generic insulin Lispro, which comes from the ImClone manufacturer whenever possible. It's the same drug entity. What we've been recommending is, and what we've had success with, is e-prescribing it as insulin Lispro. Working with your EMR vendor to not list the brand name when it goes across to the pharmacy. You may also send a note in the prescription to the pharmacist to request that they fill, if it's covered with insurance, the generic ImClone manufacturer agent. Other ways that you could take action is potentially, having a staff member call the pharmacy just to make sure that they fill the next script or subsequent script for generic, and talking with the patient as well about that. Next slide. So if you recall, one of the other initiatives that we've been working on is, and we've had a lot of success with, is avoiding the use of GLP-1 agonists and DPP-4 inhibitors in combination. Rationale for that is that there's minimal additive clinical benefit with these agents used in combination. Based on current literature, there's only an A1C reduction of about 0.3% when these agents are used concomitantly. And theoretically, because they do have overlapping side effects, there could be increased risk of some of the more serious side effects, including pancreatitis. We've partnered with Endocrine to get their buy-in for this initiative as well. And what we recommend when you see it is discontinuing a DPP-4 inhibitor, preferentially, given the GLP-1s are more potent in their A1C reduction. They promote weight loss as well as reduce cardiovascular risk and outcomes. So for this, we're typically sending outreach messages either via EMR or secure email to notify you that your patient may be on both. And oftentimes we find that it was not intentional. Perhaps one was intended to be deprescribed, it didn't get discontinued at the pharmacy, so can lead to a conversation with patients. So be on the lookout for those, because we will continue those in 2021. Next slide. Glumetza and Fortimet, you've heard this before I even started in my job, but the metformin extended release modified version, Glumetza, is super expensive still, as well as Fortimet is also super expensive. So we are recommending to preferentially use the generic for Glucophage XR. We've had folks who have updated their EMR to not allow Glumetza to be ordered, or have put pop-ups in the EMR to remind providers that they're selecting Glumetza, because it's not always obvious in the generic list in the EMR. And so I think most folks are pretty aware of this initiative, but we will continue it because even getting just one patient off of Blumetza creates thousands of dollars in savings in the contracts. Next slide. Our generic inhaler initiative is still something that we're working on. The opportunity size is not as large as it was before the introduction of generic Advair, which can be substituted at the pharmacy. So for this, we were saying prefer generic fluticasone salmeterol, generic Advair whenever possible. There is also now a generic Symbicort available. It still does not have wonderful coverage at the pharmacy. But we do understand, some patients may need to remain on their Symbicort. We know that it's a preferred agent in many of the hospitals, although it is more expensive, at cash price compared to the generic Advair. But it is now also in some of the updated asthma guidelines preferred for smart therapy for both maintenance as well as relief for asthmatic patients. So there could be a lot of reasons why a patient needs to stay on their Symbicort. So for the inhaled corticosteroid long-acting beta agonist category, we're saying, hey, if you can get the generic Advair, let's try to do it. If not, Symbicort would be our other preferred. But Breo and Dulera tend to be more expensive still. A new initiative for this year, which I think is going to be a pretty cool one, and I'll be interested to hear your specific feedback, is looking at patients who, particularly those with COPD, given the issue with Symbicort being used for smart therapy and asthma, patients may need to stay on the ICS LABA alone. But for patients with COPD who are on multiple individual or combination inhalers that contain an inhaled corticosteroid, a long-acting beta agonist, and or a LAMA. So the example here might be fluticasone salmeterol, so generic Advair, as well as tiotropium Spiriva, considering regimen simplification to one inhaler, which is Trelegy. So Trelegy is a combined ICS LAMA-LABA. It's one inhaler, it's an ellipta, it's dosed 1 puff daily. So you can see quickly that you could potentially result in simplification of inhaler regimens for patients. There's also potential for patients to have reduced co-payments at the pharmacy counter. Some patients may also observe lower out-of-pocket costs for deductibles. We know, we're quick to not promise this would happen for every patient, given the multi-payer environment we still all practice in. But for you as a provider, it could also result in a reduction in the need to titrate multiple inhalers or tend to multiple refill requests for multiple inhalers. So we will be doing outreach similar to what we do for the GLP-1 DPP-4 initiative, and sending messages based on chart review of patients that we think could benefit from simplifying, that you might want to consider simplifying their regimen to Trelegy. Next slide. NSAIDs. So, you guys, many of you I know have been to Grand Rounds before when we talked a bit about opioids, and Chad pointed out, gosh, why are we ever giving anyone a combination NSAID? There are some combination NSAID products, particularly naproxen with esomeprazole, which, per prescription costs almost $1,000. So we're just reminding folks that combination NSAID therapy can be quite cost prohibitive, particularly when you look at the allowed amounts in our contracts. So we're asking to just not do that if you can help it, and to prescribe the individual agents. And then we're also going to be putting out a table of more costly NSAID products. So Cambia, I know it has a specific indication for migraine. It's available as an oral solution. But I would reserve that for patients who are intolerant to other NSAIDs and other therapies for migraine. Chad has a message. Celebrex brand is quite expensive. Flector patch and Arthrotex seem to be the more expensive agents. Whereas, the least expensive are those that you would typically think of: meloxicam, ibuprofen, naproxen, indomethacin, ketorolac, IR only. Actually, ketorolac ER is quite expensive, but most of these drugs listed here are anywhere from $2 to $25 per prescription, compared to others that can be over $100. Next slide. And then HIV PrEP, due to confidentiality reasons, we won't be outreaching with any patient lists, But we did put out a pharmacy pearl recently, just because we know more and more prescribers and patients are interested in receiving pre-exposure prophylaxis for HIV, and PCPs are perfectly capable of prescribing these medications. But so we put out a guideline, which is based on the New York State guideline for HIV pre-exposure prophylaxis, reminding people that generic tenofovir, disoproxil fumarate, emtricitabine, which is Truvada brand name, is now available as a generic. And in fact, Truvada is indicated for all of the populations that are considered suitable for PrEP based on eligible populations in the guideline, whereas Descovy is almost 5 times more expensive. It does have some certain indications. So Descovy is tenofovir, alafenamide, emtricitabine, can be preferred. It's only approved for transgender women and cisgender men who have sex with men who have pre-existing renal disease or osteoporosis is the population it's preferred in, because it is a prodrug. It has less systemic concentrations, leads to less osteoporosis and renal toxicity. So our message here is really just, if you're prescribing PrEP, hey, we have a nice resource out there for you. Happy to engage with you on education in the practice if folks are interested in hearing more about the PrEP protocol, but to prefer generic Truvada whenever possible, given cost concerns. Because as you know, one of the goals in New York State is to end the HIV epidemic, and we need to create a way to do that. So our 2021 expectations related to all of these initiatives is first, as I mentioned, we'll continue direct outreach from our pharmacy team for the GLP-1 agonists in combination with DPP-4 inhibitors, requesting discontinuation of DPP-4 if possible. We will also make suggestions to simplify inhaler therapy to Trelegy. We will continue to outreach to prescribers that have many patients on brand Humalog requesting a change to generic, as well as those combination NSAIDs I mentioned. The provider engagement report, which you'll be hearing more about subsequently, will be providing you with feedback on performance as well as patient lists for agents that can be switched to less expensive agents. So those would be our direct switch initiatives, Humalog, Blumetza, ICS-LABA inhalers, as well as NSAIDs, and it would be PCP prescribed only. Okay. And that's all I have.
All right, thank you, thank you.
There's a comment in the chat
Yes.
relative to Erica's presentation.
Okay, there you go. I like this. Spoiler alerts all night long. All right, so thank you, Eric. Any other questions that folks have? All right, we're going to move on to the next section then. So after hearing all of that, you're probably saying, wow, that's a lot of information. How will I ever keep this straight? How will I ever know how I'm performing to that? And that's exactly where we want you to be right now, because we're getting ready to explain all of that too. So Christy Howd is our Director of Information Management, and she and her team, along with our clinical team, really, as I said before, have been working for the last 12, 18 months on what the new iteration of the triple aim report was going to look like. How can we make that more timely, more actionable, and more representative of all of the quality and clinical efforts that we are trying to undertake? And so tonight, Christy will introduce that to you, hopefully for the first time, and you'll be wowed and amazed. So I will turn it over to Christy.
Thank you. Can everybody hear me good? All right. So as Chad mentioned, this is the new provider engagement report, which we're really excited to bring to you today to show you how we're going to be moving into the 21st century here. We want to have an online electronic executive summary dashboard. A scorecard that shows you how you're performing against the reward plan and the initiatives that you've chosen to engage with the HPN. We're going to provide you really easy ways to click through to get to more detailed dashboards, to get to actionable patient lists. and just really want to make it something that's very intuitive, simple to use, but gets you the information that you need and haven't really had access to previously. We're committed to providing quarterly updates at a minimum, but we're finding that some of this information is just so easy for us to get access to, we can provide more frequent updates, which makes it more actionable to you. And we're also going to be configuring this to you and your practice specifically. So again, it's what are the initiatives you're going to be engaged in? What are you going to be held accountable to for your provider reward plan? And, where are your opportunities for improvement? So we'll take you in and give you a little tour here. So where we're at right now is what happens after you first log in. You're landing on a practice dashboard, which is a very quick look at how is the overall performance for the practice. The top is just a banner that identifies the practice and the provider that we're in. There's a little toggle near the top where you can toggle over to see your individual performance. But the components that you're seeing down below the banner is really what we want you to focus in on. Cost versus quality. This is going to be a quick way for you to see how the practice overall is doing on the per member per month, and how, when you drill into it, you'll be able to see how you compare against your peers. And also it ties back into the quality as well. And then below that top cost versus quality are various component cards. So these are the things that are going to give you a real quick look at how are you doing. So the ones that are showing in blue, the little blue circles there, those are areas that you can improve upon. You may want to click in and see what some of the details are. Where it's green, green is good. You're on target. You may not want to drill any further into them. However, we're going to toggle over now to the individual page, which is going to be a little bit different. We're not going to show you the cost quality because that's really at a practice level. We're not going to drill into the individual provider level information there. And you'll notice one of the cards has disappeared. Lark is off of this one. And that's just because this is an example of that's one of the things that this particular provider is not engaged in. And so we're not going to present it. You'll see that there's cards for quality measure performance. This is not a replacement for Arcadia. It's going to be a supplement to Arcadia. It's going to do things that you can't easily see, like trending over time. And we're still working on the design for this. We want to make it useful, but not replace functionality and things that are already in the other system. Depression screening, we're working with our EHI team on a great dashboard that shows progress on number of screenings and then follow-ups, those in patient lists around the individuals that need to have follow-ups. Citizenship is where you can see how you've done on earning the 2 points, the 2 selections for your citizenship. This is an example of what when you only have 1 out of 2 looks like. On the bottom there is readmission. We'll go into this a little bit more. The readmission IPC here, there can be, as the other IPCs roll out, they may be added to the dashboards in the future if that's what you're engaged upon. And then pharmacy costs. This is where Erica referred that you'll be able to see how you're doing on those pharmacy cost reductions, and you'll be able to drill in, seeing specific drugs, also getting specific patient lists, and we'll show you more about the details of these in future sessions. So we'll drill into readmission quickly here. So if readmission is an area you need to get a little bit more information on, you click into it. And this is an example of what a detailed drill down page will be. It tells you a little bit more briefly about the initiative, gives you some high level information. This is all example data. It doesn't correlate to anything that's specific to any particular provider. In some instances, doesn't make sense in and of itself here. But this shows what you as a practice are going to be engaged in and want to be keeping your eye on regarding readmissions. So these are the things you can influence. Contact 3, contact 4, and contact 5 are all post-discharge. And so how are you doing regarding completing those contacts? And, then on the right-hand side is an example of what a patient list is. So you can actually see who did get the contacts, who didn't. Of those who are recently discharged, do you still have the opportunity to intervene there? This isn't information you easily have access to anyplace else right now. If you need more information on the initiative as a whole, there is a little link on the prior page that just you can drill down into the Review the Readmission Initiative. And that's where you can get all the information. There's lots of words here. It's a little bit of an eye test, but there'll be links to other resources, just background information of what's expected regarding this initiative. So you don't have to try to recall what you heard in the clinical grand rounds. It'll be easy to access and find right here. And so the next screen. And so next, what you can expect from us is we're going to be coming back out in different forums, asking for more feedback on user experience. In March, we presented an earlier version of this design to 4 or 5 different groups, got some great feedback, which we've incorporated into the design. And our developers are starting to build out all of the components. We're going to have things to show you of what's behind the cards in the near future. We're going to do a demo at our fall clinical grand rounds, and a live demo. Hopefully everything will be working as designed. And at that point, we'll also be giving you more information around the rollout. It'll be coming to you in the 4th quarter so that you'll have some time to get your hands on it, get familiar, ask questions, see your 2021 performance, and be ready to hit the ground running for the 2022 year when that really impacts your reward plan. And that's all I've got.
All right. Thank you, Christy. No questions in the chat. Any live questions? So again, most of this was just to be kind of a teaser of what's to come. I think, we've definitely come a long way from the static, here's the best thing we can tell you about what happened 6 months ago, to now this will be update in the moment of your patient population, and you'll be able to go from 30,000 foot view of how my practice is doing down to the practice level of which patients do I need to reach out to today to improve my performance tomorrow. So hopefully this will be the next tier of engagement to help kind of self-direct some of that performance improvement and drive the overall network and performance improvement. All right, so now to accomplish all this, we need the glue that binds us together, and that's our care management organization. So the new queen of all that is care management, Elisa Stetzer, will tell us about what is the next phase of the care management enterprise. So I'll turn it over to Elisa.
Thanks so much, Chad, and good evening. Hopefully my volume is okay. Maybe someone could give me a thumbs up if you can hear me well. Fantastic. So for those of you who I have not yet met, my name is Elisa Stetzer, and I'm the Senior Director for Care Management with AHP, the Center for Primary Care and the Medical Center. I stepped into this role that is newly reconfigured about 3 months ago, succeeding Daryl Sharp in leading the care management organization across the medical center and overseeing the AHP community care managers. In addition to those roles, I will continue to oversee the care management infrastructure for the primary care network after serving as their director for the last 3 years. As the last person on the agenda, I realize that I'm standing, well, actually I'm sitting between you and the rest of the evening. So I want to be mindful to just take a few minutes here. I do want to talk with you about AHP and the care management enterprise and what comes next. In keeping with tonight's agenda, I will be speaking exclusively about our adult care management programs within AHP. As with any new endeavor or a new role, as I have, to sort out what comes next, it requires that we first take stock and to deeply evaluate where we stand currently. So I want to share with you some of my early observations. And as I do so, I'll posit that the work we have done to align the goals and the role of care management across the enterprise with the priorities of AHP, URMC, and the practices through the work of the IPCs, the clinical initiatives in AHP, we have set the stage for a new level of responsiveness and resilience that was urgently needed during COVID. Outside of those IPCs, I'm going to share with you how the role of care management has continued to evolve as we've learned more about how to care for our complex patients. So we're already looking at my first slide, which many of you may find familiar. I'm guessing that you've been previously grounded in the three foci of care management. This defines our work across AHP. These three foci remain the underpinnings of the care management work today, even in the face of the pandemic and the development and implementation of the IPCs. I'm not going to go through each foci in great detail, though I do want to point out a few things. The three foci are listed here in order of their attention that our care managers bring to this work. And that's actually something that has adjusted in the last couple of years. Implementing the first two IPCs, the 5-contact program and the post-acute care program that you heard about from Chad just about an hour ago, the parallel implementation of TCM billing at many practices, and the development of a much needed and a highly valued warm handoff for COVID patients post-hospitalization. All of those programs in recent times have necessarily drawn our care managers' attention to the first foci, transition care management. Transitions care management is the work of identifying vulnerable patients or high-risk discharges who are transitioning between the hospital or a SNF to home and reconnecting those patients with the PCP office. Our work here ensures that the discharge care plan is enacted or augmented to align with the clinical and social needs of our patients and families. Moving to complex care management, this is the space in which care managers work to identify the barriers that patients experience when self-managing their disease, including the social determinants that may be underlying those barriers. We have historically looked to hospital high utilizers, diabetics, patients with COPD, CHF, as ways to identify those who might benefit from a referral to care management. But as we've gotten better at identifying the social determinants for patients, those in and of themselves are another area in which our care managers and our social workers can support patients and improve clinical outcomes by directly addressing the social determinants. The care management teams have been working for the last few years to shift the work to include more of these high-risk complex care patients and away from being simply known as a diabetic nurse or a home care nurse. I'm going to talk about that in those shifts a little bit more in the complex care management model in just a minute. So lastly, care managers do continue to work in this third foci of closing quality gaps and reducing unnecessary utilization. This work is done by accessing the data in the EMR to proactively identify patients who have preventative care gaps or high utilization. Much of this work is completed in partnership with data analysts or a data coordinator. And because of those partnerships, care managers can focus on the clinically and socially driven metrics, again, working with patients to identify social determinants, connect patients to community resources, and to help overcome the challenges that these patients experience in either accessing or receiving preventative care. I also want to point out that during the pandemic, we saw data analysts, care managers, and data coordinators all working a COVID positive patient list to identify patients who might benefit from enrollment in the Get Well Network COVID loop. This is a sweet spot for our population health team, and they use their skills to serve the highest of our high-risk patients who had COVID. So I'm going to switch to the next slide, in which I want to talk just a little bit more about the shift of care managers' work towards that higher risk patient profile. Simply put, the more care managers' attention is directed towards what can be referred to as simpler care needs, or on this slide, I've listed as one touches. It does come at an opportunity cost for our complex care patients' needs that your practice or your clinical and clerical staff cannot address. To that end, care managers have worked with practice teams so that these so-called one touches alone are not a reason for complex care referral in and of themselves. So with the exception of motorized DME or hospice initiation, these types of referrals, they can be addressed by clinical or clerical staff. And our care managers have partnered with practice teams to enable your staff to both confidently and competently address these particular one touches. I do want to point out that this work is the work that care managers are engaged in when they work with a complex patient, and they're experts in this space, so they remain available to train and problem solve with your clinical and clerical teams in this particular space. Turning to the next slide, I want to acknowledge that during COVID and in this post-pandemic environment, we have seen that there are fewer community resources available. This has particularly been true of our home care colleagues. These reduced resources have introduced complexities in what otherwise is often a simpler task. So when those complexities arise, for example, the rejection of a home care initiation or a patient refusing a home care visit or even a failed transportation setup, it's quite reasonable. And care managers agree that these challenges ought to be referred back to the care managers. This shared work fosters a dialogue and it furthers the teaming between care managers and practice teams in service of our complex patients. So moving along to our last content slide, and arguably the most important message in complex care. This slide shows the space in which our care manager infrastructure excels in complex care. And on this slide, you can see the ideal reasons for referral for complex care. You'll note there is a mix of reasons included here. So there are no disease-specific states for which patients are recommended to be referred. In their place, some common social determinants, and this general statement that any patient not progressing towards the clinical outcome you expect, despite the best guidelines offered. This is in recognition that any disease can be derailed by significant social determinants, for which our care managers attend as they support patients in the management of the disease. I also want to call out those areas noted in blue. Our care managers are looking for ways to partner with our social work colleagues, our pharmacists, to ensure a more interdisciplinary approach to complex care. So as I turn to my last slide, and as promised, not delay your evening, I want to return to the three foci: transitions care management, complex care management, and the closing of quality gaps. These are the central tenets and the aims, the ambitions that align the work of all of the pockets of care management across AHP. I hope that in the last few minutes, you've heard some of the ways in which care managers continue to excel in teaming with patients and families, with your practice teams in the community, and across the health system, even as we innovate and evolve the care management model. We're settling into IPCs, the lived experience of a heightened focus on transitions, and we're wondering, as our community resources and health system recovers from COVID, how can we continue to adapt care management to address the changing needs for our highest risk patients? In my new role, I partner with care manager directors across the community and the system. And we're all asking if the balance of the three foci as they stand today continue to serve the quadruple aim. How can we prioritize the health and well-being of our practice teams, care managers, all while improving the quality and the experience of our patients and bending the cost curve? It is my aim to help the care management infrastructure move to where we think the many needs of the organization, our practices, and our patients will be down the road. We simply must keep evolving to meet the ever-changing needs of our patients and our care teams. And I look forward to working with all of you and your care management teams as we continue to evaluate these central questions to the sustained success of our care management infrastructure. And as we do this work, I'm looking for opportunities to further align and team across our healthcare settings to achieve what we've stated we need to do, which is to achieve the shared priorities of AHP, URMC, and our practices. And with that, I'll say thank you and I appreciate your time this evening. And if there are any questions, I'm happy to address them.
Thank you very much, Elisa. So no questions in the chat. Any questions from the audience? Or any questions for any of our speakers now that we've reached the concluding part of our presentation? All right, everyone took Elisa's getting to the back to your regular scheduled evening seriously. So everyone's very quiet right now. All right. So that concludes the presentations. Thank you all for coming. Hope that the takeaways from tonight are the HP team kept doing its homework during the pandemic. And so we've got a lot of good clinical value-based things to deliver. I also hope that you're a little bit reassured that as we roll out these new efforts and initiatives, that we're going to be supporting you both with the team that we have at HP, but also with these new things like the provider engagement report, which you will continue to see and hear about as that evolves and comes to fruition. If you do have any questions, things that you want to talk more about, things that you'd rather take offline, please feel free to reach out to Renee or myself, and we can triage those to the appropriate team member tonight from that presentation, or certainly you're welcome to reach out to them directly. I know one of the key questions for tonight is when will I get my honorarium? So those will be paid out in the next couple of weeks. Although if we do not have a W-9 on file for you, please make sure that we do. And if you don't know if we do, please reach out to see if we do. Otherwise, we can't give you money if we don't have a W-9. The next grand rounds, as we said before, will be more PEDS focused, but we will have the provider engagement report, as Christy alluded to before, to hopefully demonstrate rollout. So if we don't catch you during that environment, we will be demoing it for your practice and other venues, so that we'll give ample time for folks to feel and experience that before we go live with this new incentive plan and these new IPCs for the new year. But we will be touching base with you in the weeks and months ahead as we further roll out the IPCs that are already in existence, and as we start to pilot some of these new initiatives to keep improving care and keep improving our gain share return to all of you. So with that, if I don't see any coming off mute, we will call it a night. Thank you for coming, and we will finish exactly on time. So have a lovely evening, everybody. We'll talk to you soon. Take care, guys. Bye-bye.
Thank you.